Thank you. With the advent of vaccination against HPV and the emergence of new HPV testing strategies, we are now entering a new era of screening and prevention for cervical cancer. Many questions have arisen. So the first question is, and it's asked often, if a woman is vaccinated against HPV, does she need to undergo cervical cancer screening? Bob.
Yes.
It's a one-word answer.
I think while we've certainly seen a lot of progress in the area of vaccination and in the trials certainly for the specific HPV DNA types that the vaccine covers, that I think you might be able to, at some point in the future, determine that screening would be with specific testing for HPV or cytology might be redundant. I think at this point, because the vaccines don't cover all the pathogenic or oncogenic types of HPV, that screening is still indicated.
Yeah, I mean, it's there's no question because that, you know, there are 4 types in the vaccine, and 16 and 18 cause 70% of cervical cancers. What I think is going to be very interesting is likely, hopefully in the next 3 or 4 months, there will be a 9-valent vaccine that's approved by the FDA. And there, if you actually wind up mass vaccinating boys and girls, you can start making a very compelling argument that A, you can either stop screening altogether, provided that we have reasonable long-term data, or B, that just women need to be screened once in their lifetime. But as it stands right now with the current FDA-approved vaccine, they definitely need to be screened. So.
Do you alter your screening at all between vaccinated and unvaccinated?
Well, and we actually looked at this as a group, and at the present time, no, and mainly because the vaccination rates in this country they're pretty appalling. It's only about 30%. And we really have no reliable way of determining who has really been vaccinated and not been vaccinated. And, you know, I have a 12-year-old daughter, and I don't think she's going to truly remember what she got vaccinated with 10 years from now. And so the present time, the screening recommendations is really to treat all vaccinated and unvaccinated women the same way.
I agree.
And we have to do something in this country to get the vaccination rate high. This is a spectacular strategy. It's a public health issue. It can prevent cervix cancer, and there's no reason for not vaccinated.
And then the major reason is sociologic at this point.
Yeah, and this is a remarkably effective strategy at a public health level. So as a follow-up question to that, the vaccine as it was tested was obviously restricted to a particular age population. So should women older than the age 25 be vaccinated against HPV? What is the population? Warner?
Well, so in the United States, the vaccine's approved only up to 26 years of age, and so to give the vaccine past 26 would be essentially an off-label use of the vaccine, which is interesting, is really the first time ever, in my knowledge, that we're giving vaccines off-label. You know, when would you ever give a vaccine off-label since it's a preventative strategy? There's clearly data out there suggesting that you can prevent new disease and infection when you vaccinate older women. And there are other countries in the world that actually have it approved up to 45 years of age. I just think it's important to recognize in this country it's not FDA approved. We do give a fair amount of the vaccine in our office, but we do tell women that they will have to likely pay for it out of pocket. But what it does really create is a very interesting paradigm of, instead of looking at a public health effort for vaccination, we've drilled it down to the individual woman. And so, you know, I definitely think there's value, but it's the benefit is not nearly as great as someone who is a 11 or 12-year-old girl getting vaccinated.
Okay. A follow-up question to the whole question of this is, how will HPV testing fit into the current screening paradigm?
Well, HPV testing involves evaluating all the oncogenic types in a single stroke, and I think has actually revolutionized testing because I think it's increased the sensitivity and the specificity of screening. It limits the false positive and false negative data we get with very minimally abnormal cytology on Pap tests. It can allow us to potentially extend the interval between screens. The only cautionary note is that we don't want to give women send the message that go away and not have a physical exam for 3 years or for 5 years if you test negative by both HPV-based screening and cytology in combination. So I think that's not the answer, but I think that there are very well conducted studies demonstrating that with negative double screening that the intervals for that specific screening modality can be increased.
I mean, it's interesting because what we've learned in the last 10 years is that the sensitivity for pap smear is only about 50%, whereas the sensitivity for HPV testing is about 96, 97%. And so just as of this past spring, the FDA approved actually primary HPV testing for screening in this country, which is a huge paradigm shift for us. There are other countries that are looking at this, but what we know is that when you're HPV negative, it provides a level of negative predictive value and assurance that that woman's not going to get cancer at least 3 to 5 years after their testing. As a matter of fact, the Netherlands are looking at this, and they're actually thinking about extending testing to every 10 years if you happen to be HPV negative. So I think in the next several years, you're going to see a huge paradigm shift, at least in this country, in terms of how we look at screening. And I think slowly the pap smear will go away, or we'll selectively use pap smears in women who, for instance, might be HPV positive. So kind of enriching a population in terms of improving the performance of cytology and pap smears. But we know that there's no question that HPV DNA testing is better than pap smears.
Is the real issue then they're just cost?
Well, you know, there are actually multiple analysis, but the biggest factor for cost is obviously the test itself, but also the screening interval. So if you can space screening intervals out to 3, 5, 10 years, then the cost drops dramatically. The other question is, when do you initiate screening? And so for HPV DNA testing in this country, they've recommended screening actually at 25 years of age, and there's a lot of argument for and against that. But I think cost will come up over and over again, Maury, in terms of that strategy. But there's no question in my mind that eventually cytology or pap smears will not become the preferred screening strategy in this country.
And you also have to balance the cost of traditional methods involving cytology in leading to going down the garden path of diagnostic tests, colposcopies, biopsies for women with minimally abnormal pap tests that don't really have disease. And those drive cost up in the balance, I think. So the strategy makes sense.
And sort of the final question in this section is actually sort of alluded to, but I know it's asked, and I want to ask you this. If the majority of women are ultimately vaccinated against HPV, will cervical cancer screening eventually just go away completely? Do you envision a day where that could happen? It's not a strategy?
You know, I think we all will be long retired, if not dead, if that happens, unfortunately. But it's that's the goal. And but as I mentioned earlier, at least in this country, the majority are not vaccinated. It's a very low number. But what I think is a really interesting population-based observation is that Australia has had one of the most aggressive campaigns for vaccination since 2007. And we have short-term and long-term targets, and the long-term targets are cancer, and the short-term targets are genital warts. And since 2007, they've seen roughly a 97 to 98% drop in the presence of genital warts in women in that country. What's very interesting is they didn't vaccinate boys, but they saw roughly a 50 to 60% drop in boys. So we talk about this concept of herd immunity, passing on protection from one individual or one group to another group, and there's no question that the vaccine works. I just think it's way, way too early for at least the United States to say that cervical cancer screening will go away.
You want to make a comment on, as vaccination rates do go up, are we going to see a molecular evolution of the oncogenic types, or are they going to become more lethal?
Right.
Is there any data that
there's
suggests that's a
it's
risk?
this concept called type replacement, and we theoretically have no evidence to indicate that there would be types that go away with vaccination that are going to be replaced with other types that are more virulent, and it will unfortunately just be one of those things that we'll have to track over time. So unlike HIV, that the mutation rate for HPV is basically one nucleotide every 10,000 years is what they predict. So it's a fairly stable virus. But it's hard for me to imagine that the rare types are going to replace a void caused by type 16 and 18.
And I don't think there are data that they outcompete each other in a given patient, so.